Hey guys, Bob here. So I came across an interesting ECG. I thought it useful to share it with the good folks on the internet, right? If you tune into my last video, I looked at pericardial effusion. Very interesting case or very interesting ECG. I think this is equally as interesting. So as usual, I'll go ahead to let you pause the screen, analyze, make your findings, and then I'll break down the same ECG and we'll see just how close you are to making the same or similar diagnosis to me. Okay, so let's begin. This is the ECG of a person. We can see some findings and some very interesting findings. Yeah. Um, we'll take it systematically to make sure that we come to a very comprehensive analysis of this particular ECG. We'll have to start from whether this is sinus or non-sinus. This is a sinus rhythm. Yeah, we can see the P waves. This is a P wave. This is a P wave. This is a P wave. A P wave. A P wave. A P wave. P wave consistently. We could see in some cases it's there monophasic, right? In some other cases like this, it's biphasic, but it's present nonetheless. So P wave sinus rhythm. Yeah. All right. So the next thing we have to think about is the whether it is regular, right? We can see 1, 2, 3, 4, 5 and half, then 1, 2, 3, 4, 5 and half. So 1, 2, 3, 4, 5, a little bit extra, not too much, but 1, 2, 3, 4, 5 and half. So yeah, it's regular, right? It's sinus, it's regular, right? Okay, so we'll go ahead to calculate the heart rate, which is going to be 300 divided by 5.5, the number of big boxes between two RR complexes. So it's going to be 1, 2, 3, 4, 5.5. That is going to give you a rate of about 55 beats per minute, right? 55 beats per minute. So sinus, regular, heart rate of 55 beats per minute. Cardiac axis is positive on lead 2, lead 3, but it's negative in lead 1. So the QRS complex is positive in lead 2, lead 3, but it's negative in lead 1. This tells us that there is a slight deviation to the right, but that's very sorry, it's a very important context to note for this video because there's something about it I'd like to point out, right? All right, so we could go ahead to compare a few things then, right? So we have P waves present. P wave duration is normal, but we notice then the PR interval, this gap here from the P wave to the QRX complex, PR interval is shortened from the beginning of P wave to the beginning of the QRS complex is shortened. So there's a shortened PR interval, right? Normal P wave duration, right? After that, we notice an upstroke right here, right here. I need to outline this with a pen, something to this effect. This is contrary to a normal ECG where the depolarization goes straight up, comes down, and you see that this has a slow upstroke, right? This is what we call a delta wave. This is a delta wave. So I notice, and if you pay attention, you will notice delta waves on a lot of these as well. Delta waves here, 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 all over, right? Delta waves. Good. So delta waves already allows us to suspect a pre-excitation problem. Very specifically, Wolf Parkinson White, right? Uh, Due to the presence of the delta wave, we can notice then that our QRS complex is almost big, four small boxes, right? Or almost five actually, almost five small boxes, right? So widened QRS complex, as we can see in a lot of leads here. Um, there is trying to see. There's no ST elevation. Oh, actually, there is mild ST elevation on leads 2 AVL, right? Yep, that's just about it. And then we can see that we notice ST depression on leads 1, leads 2, and leads 3. Right? ST elevation on leads 1, leads 2, leads 3. This seems to suggest a posterior MI, a posterior infarct, right? So our summary of our findings: P wave sinus, regular, cardiac axis shift to the right. Very important to notice in this particular instance where we suspect pre-excitation with Wolf Parkinson White, right? ST depression in leads V1, V2, V3, widened QRS complexes. Yeah, so ultimately, this is, like I said, Wolf Parkinson White, and the shift of the axis to the right is apparent, and there is the appearance of a posterior infarct. So this is a summary. P wave, sinus, regular cardiac axis shift to the right, heart rate of 55 beats per minute, P wave duration is normal, shortened PR interval of less than 40 milliseconds. There is widened QRS complex greater than 120 milliseconds, in fact, almost 200 milliseconds. There is delta waves in all leads, right? Positive and upright T waves in 1, 2, 3, AVL, AVF, V5, V6. Then there is ST depression in V1, 2, 3. And then R wave greater than S wave. Sorry, the ratio of R wave to S wave greater than 1. This just means there's a positive R wave in V1. Wolf Parkinson White syndrome type 1. That's the full ECG diagnosis. So what is Wolf Parkinson White? It's the presence of an accessory pathway called bundle of Kent. And then this gives rise to episodes of tachyarrhythmias and is sometimes called pre-excitation syndrome. So this accessory pathway, this accessory bundle allows the ventricles to be depolarized before the impulse passes through the AV node. So it passes through the accessory pathways and depolarizes the ventricles beforehand. I think I'll start including images of the mechanisms so you guys have a better idea of what this is talking about. Key findings: PR interval is shortened, like I pointed out, presence of delta wave, and then widened QRS complex greater than 110 milliseconds. Remember, ours is almost 200 milliseconds, right? What are the peculiarities of this ECG? Wolf Parkinson White may have two interesting quirks. There's apparent cardiac axis shift to the right. We did see a cardiac axis shift to the right, but this is apparent because of the pre-excitation. And then there'll be a pseudo-infarction pattern, negative deflected delta wave in inferior anterior leads or prominent R waves in V1, V2, V3, making a posterior infarction, right? So we can see I've highlighted some of the changes, the delta waves, right? The delta waves, reciprocal changes, right? ST depression in V1, 2, 3, which would suggest a posterior infarct On the opposite side, positive R wave on V1, right, suggests a pseudo infarction, shortened PR interval. But ultimately, those are all the findings. Left-sided versus right-sided Wolf Parkinson White. Sometimes you have to understand how to notice and distinguish this, right? So a positive delta wave in all precordial leads is type A. It's called a type A or left-sided Wolf Parkinson White syndrome. Positive delta wave, right? In all precordial leads. We can see it here. So this is what we call a type A Wolf Parkinson White syndrome. And then negative delta waves in V1, V2. We don't have negative delta waves here because this is a delta wave. But if it were upside down, sort of like in AVL, right? In AVL, this is a negative delta wave. We would say, if we saw that in V1, V2, we would say that is a type B Wolf Parkinson White. All right. Thank you very much for paying attention. Really appreciate it. Like, share, subscribe, and I'll see you on the next one.